Picture this. You have been taking your blood pressure medication faithfully for months. You feel fine. Your numbers look better. Your doctor seems pleased. And then, slowly, quietly, something shifts. Maybe your ankles feel heavier than they used to by evening. Maybe there is a tickle in your throat that will not go away no matter what you try. Maybe you feel a little unsteady getting out of bed in the dark. You dismiss it. You blame it on age, on the weather, on too much salt at dinner. And in that dismissal, you miss the one thing that could protect you most, the recognition that your medication is speaking to you, and you do not yet know its language. That is what today is about. I am Dr. Naira Stein, Seniors Health and Wellness Consultant. If you are taking Amlodipine, Losartan, or Lisinopril, 3 of the most widely prescribed blood pressure medications in the world, there are 11 things you deserve to understand clearly. Not because anyone is hiding information from you, but because most clinical appointments are 15 minutes long, and 15 minutes is not enough time to explain what these drugs are genuinely doing inside the body, what warning signs to watch for, and when a symptom crosses from inconvenience into emergency. Stay with me through this conversation. It may be the most practically useful health information you receive this year. Number 11. These 3 drugs are not interchangeable, and that distinction changes everything. The first truth is foundational. Most people assume that blood pressure medications are variations of the same idea. Different brands, similar effect. They are not. Amlodipine belongs to a class called calcium channel blockers. Losartan is an ARB, an angiotensin receptor blocker. Lisinopril is an ACE inhibitor. They all reduce blood pressure, yes, but they do it through completely different biological pathways. And because the pathway differs, so does the entire profile of how each drug behaves, what it affects beyond blood pressure, and what warning signs it produces. This matters more than most people realize. If you start coughing on lisinopril and assume all blood pressure medications cause coughing, you may abandon treatment entirely when a simple switch could have solved the problem. If your ankles swell on amlodipine and you assume your heart is failing, you may spend weeks frightened about the wrong thing. If losartan feels well tolerated and you assume there is nothing to monitor, a potassium imbalance may be quietly building in the background. Knowing the class of drug you are taking is not medical trivia. It is the lens through which everything else in this conversation becomes interpretable. Number 10. Amlodipine and ankle swelling, the symptom that fools everyone. Margaret was 73 and could not understand why her shoes felt tight by mid-afternoon. She had been watching her salt. She had not changed anything. And yet there was a visible groove pressed into her calves every evening where her socks had sat. She assumed it was her heart. Her daughter assumed the same. What neither of them knew was that she had started amlodipine 6 weeks earlier. Amlodipine relaxes the walls of small arteries more effectively than it relaxes the accompanying veins. Blood flows into the lower legs more freely than it flows back out. The result is a pressure buildup in the tiny capillaries that pushes fluid into the surrounding tissue, not because the heart is struggling, but because the drug is doing precisely what it was designed to do, with a predictable mechanical consequence. The swelling is typically soft, worse by evening, better by morning after a night lying flat, and concentrated around the ankles and feet. It is not dangerous in itself. But it becomes dangerous when it is not recognized, when people stop taking their medication out of embarrassment or discomfort without telling anyone, and their blood pressure climbs silently back toward crisis level. If you notice ankle swelling on amlodipine, that is not a reason to panic. It is a reason to call. There are adjustments available, but silence is not one of the safe options. Number 9. The lisinopril cough. late, stubborn, and frequently misidentified. A dry, persistent, nagging cough that does not produce anything, does not respond to lozenges, tends to worsen at night, and feels like a constant irritation at the back of the throat. This is the signature side effect of lisinopril, and the reason it so often goes unrecognized is that it frequently does not begin immediately. Sometimes it starts within days, sometimes weeks. Sometimes it appears months after the medication was started, which is exactly when people stop connecting the symptom to the prescription. They blame the season, the dust, reflux, the heating system, the new detergent, and all the while the cough goes on, disrupting sleep, draining energy, and reducing the quality of life in ways that never get reported. This matters profoundly because a patient suffering in silence from a correctable side effect is a patient who will eventually stop taking their medication without telling anyone. And that is precisely the outcome we most need to prevent. Here is the critical distinction you must hold clearly. A dry cough on lisinopril is frustrating. It is not typically dangerous. But there is another reaction associated with this class of medication that is dangerous. Swelling of the lips, tongue, face, or throat, especially if it affects breathing or swallowing. This is called angioedema. It is rare, but when it occurs, it is a medical emergency that does not wait for a Monday morning call. If you ever experience throat tightness or difficulty breathing while on an ACE inhibitor, you move immediately. Not tomorrow, now. Cough equals conversation. Throat swelling equals emergency. Know the difference. Number 8. Potassium and the hidden source no one warns you about. Robert was 74, conscientious, and genuinely motivated to take care of his heart. He reduced his sodium, started reading nutrition labels, and proudly switched to a salt substitute because he had read it was better for blood pressure. What no one had told him was that many salt substitutes replace sodium with potassium chloride. He was also taking Losartan. Both Losartan and lisinopril can raise potassium levels in the blood, a process called hyperkalemia, because of how they interact with the hormonal system that regulates kidney fluid balance. In most circumstances and at normal dietary intakes, this is manageable. But potassium also arrives from sources people do not think to mention to their doctor. Certain electrolyte drinks, heart-healthy seasoning blends, meal replacement products, and over-the-counter supplements marketed for energy or hydration. The symptoms of elevated potassium can be subtle at first: muscle weakness, fatigue, occasional palpitations, a vague sensation that something is off. Or they may barely register until the level is high enough to affect the electrical rhythm of the heart directly. Robert was not being careless. He was following every health rule he had ever been given. The danger came from a gap in his knowledge, not a flaw in his intentions. If you take Losartan or lisinopril, potassium is not a topic to file under general wellness. It is a specific safety consideration that deserves a direct conversation with your prescribing clinician. Number 7. When kidney numbers change and why that doesn't always mean what you think. Sharon was 71, and when her lab results appeared in her patient portal 2 weeks after starting lisinopril, she saw numbers she had never seen move before. She was a breath away from stopping the medication that same evening. Here is what Sharon did not yet know. Losartan and lisinopril are not only blood pressure medications. In the right patient, they actively protect kidney tissue over the long term by reducing the pressure inside the kidney's filtering system. But when first initiated, or when the dose is adjusted, they can produce a small, temporary change in the kidney function markers visible on blood tests. Not because they are injuring the kidneys, because they are altering the pressure dynamics in a way that causes an expected, often acceptable shift. The question is never simply whether the number moved, it is how much in which direction, against what baseline, and whether the trend is stabilizing or progressing. That requires clinical interpretation, not portal-based panic. This is exactly why lab monitoring following the initiation of these medications is not administrative routine. It is part of the treatment itself. A result that looks alarming in isolation may be entirely expected and acceptable in context. A result that looks mild may warrant attention if it continues moving in the wrong direction. Only someone reviewing the full clinical picture can tell you which you are looking at. Do not guess. Do not stop. Call. Number 6. Dehydration is the variable that changes the rules overnight. Frank was 78 and had never missed a dose of his Losartan. He was proud of that. When a stomach virus hit, he took his medication that morning as always, barely managed to eat, and spent most of the day unable to keep fluids down. That evening, he stood up from the couch and the room tilted. He caught himself on the wall. In the emergency department, his blood pressure was low, his kidneys were under strain, and the team recognized immediately what had happened. It was not that Losartan had stopped being safe. It was that his body's fluid balance had changed so significantly that the same dose was acting in a completely different internal environment. The drug had not shifted. The context had. Losartan and Lisinopril both lower blood pressure through mechanisms that depend on adequate fluid volume to function safely. When vomiting, diarrhea, reduced appetite, heavy sweating, or illness significantly reduce that volume, the blood pressure can fall too low, the kidneys can come under stress, and the medication that was protecting you yesterday can become a problem today. Every patient on these medications needs a sick day plan. What to do when illness makes normal hydration impossible. When to hold the dose and call for guidance rather than power through. This is practical knowledge that prevents real emergencies, and most patients never receive it until something goes wrong. Number 5. The painkiller in your cabinet that is not as innocent as it looks. Carol was 73, took Lisinopril for blood pressure and a water pill for mild leg swelling, and used ibuprofen several times a week for arthritis in her hands. Each of these things felt ordinary. None of them came with a warning about the others. Over-the-counter anti-inflammatory medications, ibuprofen, naproxen, can reduce blood flow to the kidneys and blunt the pressure-lowering effect of medications like Lisinopril and Losartan. Combined with a diuretic and any degree of dehydration, they can create the conditions for kidney injury more quickly than most people would expect. And because patients rarely think of something purchased from a pharmacy shelf as a medication worth disclosing, the combination goes unreviewed for months. When Carol's lab results began deteriorating and her blood pressure became harder to control, the investigation was not complicated. The answer was already sitting in her bathroom cabinet. Once the anti-inflammatory was removed and safer pain management options were identified, the picture improved. But the damage required time to reverse. If you take Losartan or Lisinopril, regular use of over-the-counter anti-inflammatory pain medication is a topic for your doctor. Not because it is always prohibited, but because it requires informed management rather than assumption. Do not wait to be asked. Bring it up yourself. Number 4. Dizziness is not always something to laugh off. Joseph was 80, lived alone, and prided himself on his independence. 2 days after his amlodipine dose was increased, he stood up in the bathroom at 2 a.m, felt the room shift, and grabbed the sink. He did not fall, but for a few seconds he was entirely at the mercy of a house that did not know he was unsteady. All 3 of these medications can cause dizziness, particularly when standing up after lying down, when starting treatment, or when the dose is increased. The blood pressure drops slightly before the body's compensatory systems catch up, and in that gap, balance is temporarily unreliable. In a younger person, that gap is measured in seconds and rarely causes harm. In an older adult living alone, moving through a house with hard floors in the middle of the night, the same gap is a genuine fall risk. And falls, in people over 65, are one of the most serious and consequential health events medicine encounters. Mild dizziness early in treatment may resolve as the body adapts, but dizziness that is persistent, that causes near fainting, or that arrives with sudden intensity is not something to endure quietly. Rising slowly, sitting on the edge of the bed before standing, and knowing that nighttime bathroom trips deserve extra care, these are practical precautions that should be stated plainly at the time of prescribing, not discovered after a frightening episode. Number 3. One blood pressure reading is not a verdict. Diane checked her blood pressure every time she felt anxious, which became more frequent as she became more anxious about her blood pressure. A high reading triggered another reading, then another, then a page of numbers taken minutes apart in a state of mounting alarm, all of which she interpreted as evidence her lisinopril was failing. Blood pressure is not a static measurement. It responds to stress, posture, caffeine, pain, conversation, sleep quality, and the anxiety of being measured. A single reading taken in emotional distress tells you less than almost any other clinical data point. What tells you something real is a pattern of readings taken consistently at the same time of day, after 5 minutes of rest, over days and weeks. Medications like Amlodipine, Losartan, and Lisinopril are designed to shift that pattern over time, not to produce a perfect number on demand. Judging their effectiveness by any single reading and making dosing decisions based on that judgment produces exactly the kind of chaotic, fear-driven medication management that causes the most harm. Measure consistently, interpret honestly, and bring the pattern to your clinician, not the single number that frightened you on a Tuesday. Number 2. Missed doses are not a reason to double up. Martin was 75 and managed his medication faithfully, most of the time. When he missed a morning dose, he would take it whenever he remembered. If he noticed his readings were high later in the day and could not remember whether he had taken his lisinopril, he would sometimes take another tablet, reasoning that the risk of high blood pressure outweighed the risk of a double dose. One evening, after a high home reading frightened him, he took an extra tablet before bed. By morning, he was so unsteady he could not walk to the kitchen without holding the wall. Blood pressure medications are not rescue drugs. They are not designed to respond immediately to a spike and resolve it within hours the way a fast-acting painkiller addresses a headache. They work through sustained, consistent blood levels that create a stable, long-term reduction in vessel pressure. Taking 2 doses to compensate for a missed one does not double the protection. It doubles the drop. And a blood pressure that falls too far too fast carries its own serious consequences. The standard guidance for most of these medications is to take the missed dose when you remember, unless the next scheduled dose is close, in which case you skip the missed dose entirely and resume normally. If you are unsure what the guidance is for your specific medication, ask. Do not guess. The rules exist for precise reasons. Number 1. The right medication is the one your body can live with long term. This is the truth that contains all the others, and it is the one most rarely stated with sufficient clarity. Teresa had excellent blood pressure numbers on lisinopril. Any clinician reviewing her chart would have considered her case well managed. What the chart could not show was that Teresa had been coughing every night for 3 months, sleeping in 2-hour fragments, waking exhausted and dreading the pill in her organizer. She said nothing because she assumed the answer would be, "You need it, so tolerate it." And in that silence, she began forgetting doses. Not forgetting, avoiding. The resentment of a medication that costs you sleep every night is a powerful and rational force. First you miss a day, then two. Then it becomes a quiet rebellion that nobody notices until the blood pressure has climbed back to where it started, and everyone is trying to understand what changed. Teresa did not need to suffer. The cough was a recognized, correctable medication effect. When it was finally identified and her treatment plan was reviewed, a different approach resolved both the symptom and the non-compliance in a single conversation. But the months of unnecessary suffering and the months of quietly drifting toward undertreated hypertension were real costs that a more open, early conversation could have prevented. The most effective blood pressure medication is not the one that produces the lowest number in the first month. It is the one you understand well enough to take correctly, recognize the warning signs of, and communicate honestly about when something feels wrong. Every symptom described in this conversation, the ankle swelling, the cough, the dizziness, the fatigue, the muscle weakness when potassium drifts, is biological information. It is your body responding to a powerful medication and reporting back on how that response is unfolding. Your role is not to diagnose what you are experiencing. Your role is to notice it, name it, and report it early, before it becomes something that required an emergency department to resolve. Being a cooperative patient does not mean being a silent one. The patients who fare best on these medications are not the ones who never complain. They are the ones who pay close attention, speak up without waiting for certainty, and treat every unexplained symptom as a question worth asking rather than a burden worth carrying alone. Watch for ankle swelling and heaviness on amlodipine. Watch for the persistent dry cough on Lisinopril, and know the difference between that and any swelling of the lips or throat, which is a different situation entirely. Watch for the subtle signs of potassium imbalance on Losartan or Lisinopril. Know that dehydration from illness changes the rules. Know that the painkiller in your cabinet may not be as neutral as it seems. Know your medication by class, not just by name. And above all, understand this. The blood pressure number on the monitor is not the whole picture. You are the whole picture. And a treatment plan that protects your arteries while undermining your sleep, your balance, your kidney function, or your willingness to take the medication at all is not a treatment plan that is fully working. I am Dr. Naira Stein. This conversation is offered in the spirit of education, not as a substitute for the guidance of the physician managing your specific case. If something in what you have heard resonates with your experience, bring it as a specific, informed question to your next appointment. That conversation, approached with knowledge rather than anxiety, is one of the most valuable things you can do for your long-term cardiovascular health. Take good care of yourself. I will see you in the next one.